Welcome to this week's podcast by Step Kids Nutrition, where we explore matters related to pediatric nutrition with an invited guest. My name is Professor Roseanne Meyer. I'm a specialist pediatric dietitian with almost 30 years of experience in pediatric nutrition. In each podcast episode, we will dive into the science and also practical tips behind topics related to childhood nutrition with an invited specialist. Whether you're a healthcare professional, a parent, or just interested in pediatric nutrition, you're at the right place. I'm absolutely delighted this week to have a friend and also a colleague who's a specialist pediatric speech and language therapist, Sandra Grosso, with me today. Sandra, you've got a long biography. I've shortened, as you know, but in short, you've got more than 25 years of clinical experience. You're a pediatric speech and language therapist that's registered in the UK, but you're like me, you also qualified in South Africa.
Absolutely.
You have got extensive postgraduate qualifications, and really your training after that has gone into assessing and managing feeding difficulties, starting in the preterm infant and really moving towards the whole kind of course of pediatrics. You and me started working, I was thinking together, I think in 1997, or was it 98?
It was. I think it might have been 98.
Yeah, so it's coming up to 18. Yeah, it's really coming up that we're coming to almost 30 years. I was thinking
Wow.
That's a lot. So, Sandra, thank you so much for being here. The focus of our discussion today is the role of a speech and language therapist when it comes to feeding.
Absolutely.
So, Sandra, I want to ask, because that's a question that a lot of parents ask me. When I say, look, I think you need to see a speech and language therapist, they're kind of going, but my baby's only 7 months, they're not talking. So what is the role of a speech and language therapist when it comes to feeding?
Roseanne, first of all, thank you so much for asking me to be on your podcast. It's really been an amazing working relationship we've had. And I think we've grown together over the years.
Yes.
You know, we've learned so much together, and it's been an incredible journey. And absolutely, our titles are speech and language therapists. So people are understandably perplexed as to where feeding comes into it. But actually, feeding and swallowing is a well-known area in our profession. And as undergraduate students, we undergo training on the physiology and anatomy and neurology of feeding and swallowing across the lifespan. But those of us who then go into feeding, I mean, I myself in South Africa at university, I was really always very interested in feeding and swallowing. And so I used to attend extra lectures. And as soon as I could, I went to work, as you know, in a hospital in South Africa. And I started working with feeding and swallowing across all age groups really early on in my career. But those of us who go into this area develop extra expertise and skills by obviously attending a lot of postgraduate training courses along all the aspects of feeding, be it prematurity, be it infant and pediatric dysphagia, be it sensory-based feeding problems, be it neurodevelopmental feeding problems. And our whole skill set completely expands because feeding and swallowing is really, as you know, so complex and multifactorial and is based on the age of the client, the etiology of the client. So really, as speech, language, communication, feeding and swallowing are really interconnected parts of the oral structure, we are uniquely placed to assess and manage feeding and swallowing problems.
And that's beautifully said. And what I should have said also with the introduction is, of course, you do video fluoroscopies as well. So you've got all of that. Those are all extra skills and extra qualifications that you've got.
Yeah, and they require clinical competencies. So it's a journey to become a clinical expert in any area. Yeah.
Of course. The shame is that in the UK, being a feeding therapist, does not quite exist. So I know in the US, people can call themselves feeding therapists on top. Yeah. But I know what you are worth and what you've done with all of my patients and so on. But I think a good base is really because this would be healthcare professionals and parents. What happens with oral motor skill development? So if we kind of go through the different early life stages, because it's such an important part of association with feeding. So can you just quickly run, and this is not a scientific presentation, but just to quickly run, what are the oromotor kind of skills that the child needs to achieve?
Absolutely, Roseanne. And you know what we always say is feeding is a developmental process, the same as walking, talking. So it follows really a predictable progression from reflexive feeding to voluntary control. And actually, babies start swallowing amniotic fluid between 13 and 15 weeks of age, which is quite incredible. And this swallowing of the amniotic fluid is actually critical for the development of the gastrointestinal tract. And actually, by the time they are ready to be born at term, they are actually swallowing almost half of the amniotic fluid, which is really amazing to think about. And in the newborn period, obviously, which is until about 3 months of age, feeding is largely reflexive. We are mammals and we are born to suck. So we are reliant on the rooting reflex, on the sucking reflex, and on the swallowing reflex to obtain the milk. And it's really the fine and integrated coordination of breathing, sucking, and swallowing, which enables a baby to effectively feed. And then, of course, as they move beyond that phase towards the weaning period, which is more or less 6 months, those reflexes then integrate and they begin to obtain more voluntary control of their lips, the tongue, the jaw, as they prepare themselves for the introduction of solids. And of course, that involves other developmental aspects like putting objects, safe objects, exploring objects with their mouth and getting ready for the oral sensory motor aspects of feeding. And then, of course, we get towards the weaning, which is when you and I often get involved, don't we? Things can go wrong, which I'll come on to later. But that's when mothers will typically start with the weaning process. And that's obviously involves an evolution and developing towards chewing, using their tongue in different ways. So starting less with a suckling action and lifting the tongue up more, dealing with smooth purees, and then as we progress beyond that, to textured purees and finger foods. And it's really developing those skills as we get exposed to more complex food textures and finger foods. And really, it's learning to clear the spoon with your lips, learning to push the food back, to swallow it, exploring the food with your mouth. So those chewing skills maturate, and it starts with the lateral tongue movements. So the food is moved onto the gums, and then that evolves beyond, from 9 months onwards, 12 months, 18 months, as we get into those more challenging food textures and finger foods, into the diagonal, lateral, and rotatory tongue and jaw movement. So it's all an evolution, a developmental process, a neurological process, but also it's a function of experience. And that's what's so important to understand, is that babies learn as they go.
Yeah. And I think we both always think about the wonders of how there's the sequence of this happening and how amazing it is when you have it all aligning. Now, Sandra, unfortunately, we get involved when it gets disrupted.
Absolutely.
And the journey can get disrupted from, as you said, from birth and along the whole period of time. You and me, if it's disrupted now, we have our cognitive skills to kind of going, okay, it's because I've got reflux and all of those things.
Mm-hmm.
Tell me, what are the factors?
Mm.
And in particular, from your experience, that can disrupt, for example, the suckling or this complementary feeding, the weaning period to solids.
Absolutely. And there are so many things that can disrupt it. So in the very early days, it's medical, structural factors. So it's things like prematurity, neurological differences, hypotonia, which is low tone, structural differences or difficulties like cleft palate, gastroesophageal reflux, which is one of our big areas, you and I, and also a chronic, for example, respiratory difficulty, which is going to impact on the baby's endurance, cardiac difficulties. I used to work at the Brompton. So all of these factors can derail that early sucking and that actual a coordination of the breathe, suck, swallow, which is actually one of the most complex and integrated neurological aspects of development, is that breathe, suck, swallow.
And Sandra, so let's just have a think. So breathe, suck, swallow, because we know children don't breathe, suck, swallow for, forever. So if we have that, and you then have, for example, those children that struggle with textures, for
Mhm.
example, 7, they just do not progress. Is that a
Absolutely.
factor of what happened before or what's happening then?
Absolutely, Roseanne. And I think that's really important because sometimes babies will start from the off. Mothers will say there's a problem, as we know. Mothers will notice vomiting, will notice discomfort, will notice back arching, and that will alert them that something's wrong. And then often they will contact, their pediatrician, who will then refer to us or other professionals, gastroenterology colleagues, etc. But sometimes it's only when the weaning starts that one is actually aware that there is a problem. And that is when we notice this baby is not tolerating textures, certain finger foods, is gagging, is retching. And that is telling us, often that informs what might have happened before and that wasn't noticed, because these signs can be quite subtle, as we know.
Yeah. And I think you lead nicely into what are the symptoms. You mentioned gagging, but what are the symptoms? If
Mm.
we can put them, symptoms is always a difficult term.
Yeah.
How do children that have got feeding difficulties present? What do you see?
And the most, I think, common symptom is this process is derailed. All those nice adverts that you see of babies enjoying their eating and just immersed in their puree. Mealtime has become a struggle. There is, as we know, sometimes a reticence to accept any purees. The baby might accept smooth purees and then not cope with textured purees, gag, retch. So that's as those stages progress, as I described earlier, it isn't going smoothly. Food, such as finger foods, more complex foods, which involve different oral motor skills, are not tolerated. So babies might suck the juice of a piece of fruit and then expel the pulp. They might retain food in their buccal or cheek pouches. They might delay their swallow. They might retch and gag with any texture. So it manifests in different ways. But basically, the parents become aware that the baby is not coping with that normal progression of complementary foods.
And I think this realization, I think we'll have a lot of parents and healthcare professionals to kind of listen to you speak. I suppose it is not a question we had thought about before, but when would you say to parents, you need to get in touch, or a healthcare professional say, refer on to you? You were talking about this progression and so on, but when do you kind of going, oh my goodness, this is really concerning, see somebody?
I think that is such a good question, Roseanne, because I think that often mothers do present to their GP, as we know. They might present to their GP, they might present even to their pediatrician. And when babies are growing well, there is a tendency to say, well, the baby's fine. There are no concerns developmentally or with growth. But actually, often mothers are spending their days and their nights getting milk in. Mothers are exhausted, understandably. Feeding is becoming very, very challenging. And solids are it's just not going smoothly. Solids become a battle. There is a challenge to progress through those textures, through those stages. And actually, I think it is so worthwhile going to see a professional sooner rather than later, addressing any issues so that we can prevent the entrenchment of those difficulties. Because I think over time, as we know, it becomes harder and harder. Those stages then have passed. Babies might have missed those critical window periods. And then it gets harder and harder. The whole mealtime becomes all-consuming and stressful. And actually, often, as always, early intervention can identify the problem, whatever it may be, nip it in the bud, and support that smooth onward transition.
And I think that's where, I know we've been very fortunate to work together, but we also work with other healthcare professionals where if with somebody that knows, you would very quickly then say, actually, Roseanne, I've seen this patient. I actually think you should see them. Or I would go, and we often also say psychology needs to be involved or occupational therapy. It's the kind of, we overlap. And that's I think an important recognition in understanding that it's not that we work in little boxes. There's always an overlap. And I do want to reinforce for the listeners, because we are so on the same page on this one, that if you have a feeding difficulty in the younger child, a child is not born with a behavioral feeding difficulty. And it's a term that both you and me kind of really gets us really upset.
Absolutely.
But it's really that In the vast majority of cases, there is an organic cause to it, and you've listed them very nicely.
Totally.
But what often happens is you can even have an organic cause. So we often see that the reflux is managed, we've got it, but you sit with the residue or
Totally.
the history of that.
Absolutely. Absolutely, Roseanne. I think that is so powerful what you're saying. First of all, eating is obviously a natural process. And very often, children are perceived to be picky eaters. And actually, it's not picky eating. I think it requires a specialist eye to differentiate, because eating is actually, as we know, extremely complex. That is why there are so many different aspects to it. That is why there are so many different professionals involved in a feeding issue, because it is so much more than just taking food in, biting it and swallowing it. As we know that there are 32 steps from food getting into our environment and getting into our mouth. So there is the sensory system. One needs to be able to accept what food looks like. We eat with our eyes.
Yeah.
The smell of the food, the temperature of the food, the taste of the food. And all those aspects are really, really big in our work. That is where we liaise with our occupational therapy colleagues. And then, of course, there's the motor component, as I mentioned, the oral motor skills, the biting, chewing skills, the drinking from the cup skills, and all the other skills involved, the complex chewing skills. And what happens is, when this smooth feeding journey is interrupted through things like gastroesophageal reflux or allergy, babies and children may become more selective. Now, it can start off with aversion. In other words, the baby rejects the bottle, the baby rejects the breast, because obviously babies learn through association. They're in pain, and so they stop eating or drinking. Alternatively, when it comes to solids, there is really that difficulty. Sometimes the solids are entirely rejected, as we know. And sometimes it's really specific to food texture. So it's the textured solids, the lumpy solids, the finger foods, different colored foods can be rejected. So it's so wide in its presentation. But often, as we said, if you go back, you will find an organic basis to this. And this is often, as we know, gastroesophageal reflux and allergy are real culprits here, because babies from early on might experience pain. And as we know, those afferent pathways, those nerves are picking up, the sensory experience is distorted, is unpleasant. And so all subsequent sensory experiences are perceived as a threat, as dangerous, and as unpleasant. So our job really is to identify the driver. What is the driver? Always. I always say it's a stool with 3 legs. We've got to identify what is the driver, and we've got to tackle that. And that we work as a team. We've got our gastroenterology colleagues, our allergy colleagues, our OT colleagues, our psychology colleagues, and us, and we work out what is the driver, and we tackle that. And then we've got to look at getting a positive experience back to feeding, both for the child or infant and for the mother. Now, normally, when pain is taken away, those normal hunger cues come back, eating becomes less of a challenge. However, as you've said, there is the legacy. And often there's a really adverse legacy of this is not a good experience. The child has now developed a bad association with the high chair, with food, with meal times. And so we've got to unpick all of that. And then there's the developmental aspect. That's the third leg. We've got to get the child back to those developmental levels and help them progress through those. So it's a work that is really integrated all the time.
And I think listening to you, again, I mean, we live it, but this frustration that parents often share with us of either very slow or lack of progress, because we take them back. We kind of going, okay, now you first play with food and you experience and the visualization. But it's really highlighted again, this importance of, you need to see food, you need to go, oh, that looks quite nice. Then you smell, and then it feels quite nice because, of course, as you said, it's a matter of experience. That's how you learn.
Absolutely.
Sandra, I wanted to kind of go a little bit into the sensory side because I think we often have been frustrated with saying, is this an oral motor, is this dysphagia or is this sensory? And you've always tried to kind of go, Roseanne, there's this very clear sensory. But, and where there is no coughing or spluttering or where we need to change the textures, but you kind of go, how do you distinguish with, okay, this is oral motor and that is sensory?
Absolutely, Roseanne. That is a brilliant question. So obviously, as speech and language therapists who are feeding and swallowing experts, we know about swallowing and we know about eating and we know about oral motor skills, biting and chewing and drinking skills, etc. And often parents will say, my child is choking. And that is a legitimate concern that must be assessed. Now, there is the dysphagia, which is a swallow incoordination, a swallowing problem. And that is when, if we eat or drink, food may go into our lungs. And that we assess. We assess swallowing in from prematurity all the way through all the age groups. And then there is the sensory aspect, as you've alluded to. And what is that? That shows up when we give a texture that is overwhelming to the child or to the infant, and they will gag and they will retch, and they might even vomit. And that really can look like choking. So the skill of the clinician is actually because it's possible for both of those to co-occur simultaneously. So it's the skill of the clinician to discern between those two aspects, because there are some children who do have swallowing problems and who need treatment for that, as well as sensory-based feeding problems. So what happens is, if I don't like lumpy purees, if I prefer smooth purees from a sensory texture perspective, I might gag, retch, and vomit with lumps. What happens is, if I'm given textured lumps, I will retch and vomit. So my mother stops offering them to me, logically. So I might stay for a longer period on smooth, and then it becomes harder without expert advice on how to move the child forward through those stages. And that's the same with finger foods. But also, as we've said many, many times to our families, so if you give me chocolate, I'm going to move that chocolate around in my mouth, every corner of my mouth. I want the full sensory experience of chocolate. I want it to coat my whole mouth, my palate, because I can't have too much of it, and I really love it. But if you give me liver, I know for you it's avocado, but if you give me liver, which I really don't like, I will, if I'm on my own, I will expel it. If I'm in public, I will store it in my cheek pockets until I can expel it later. I will keep it in the center of my mouth. I might knock it down with some water and swallow it. But I'm not going to move that liver all around my mouth, because the last thing I want is the sensory experience of liver. And that's where we come to sensory motor. The one is the skill of biting, chewing, drinking, and that is a developmental skill that is learned through experience. And then there is sensory. Can the child tolerate the sensory experience of eating that particular food? And that's what our job is to look at all of these aspects in order to move the infant and the child forward.
And I think that's such a beautiful way of saying it's looking at what the journey has been. And I know for those people listening, we often send them back to the physician saying, look, there's a driver. And that can also affect your sensory perception, because if a child is in pain, I always kind of, you have been sick and I've been sick, and I can feel how, everything feels heavy. So your sensory perception is affected. And often then it's kind of saying, picky eater and all of that. And you've touched on it, that picky eating is really something very different to what we're dealing with. And that requires somebody that knows their way around it. Sandra, as we're coming to the end of this discussion, I mean, I could talk to you the whole day. The reality is we'll have both parents as well as healthcare professionals listening. Are there factors that you say you can do for prevent? We'll come to, tips to kind of what should you do if you think something goes wrong. But do you think there are ways to prevent having a child that has feeding difficulties?
I think in some cases, it's really about, if it's organic, such as allergy, reflux, which is causing the problem, it does need to be addressed. So
and actively. I want to come in. Actively, it really needs to
and promptly.
Yes. Yeah,
That for sure. But in general, feeding is really a sensory experience and a motor experience, as we've said. So it's about looking at the child's stage of development. It all follows a very logical sequence. So obviously babies around the time of weaning, they're starting to sit up. They're interested in what their parents are eating. They want to be part of the family meal times. And we live in a very sanitary world now. And it's really about getting your hands in there. I always say the messy feeder is the happy feeder. Get the
absolutely.
hands in there because it's the one of the most sensory, if not the most sensory experience we do as humans. So it's getting your hands there, it's touching the food, it's smelling the food, it's exploring the food, it's putting stuff to our mouth. Of course, weaning can follow, obviously, purees and then finger foods. And obviously some babies are going straight onto baby-led weaning and doing perfectly well. It's really up to the individual child, really. But it's really about opportunities for exploring that are in line with the stage of development of the child. But keeping it in the family, a social event, allowing opportunities to explore, immersing our hands into food, visually seeing food, putting food in the center of the table and the whole family is eating and children are seeing their parents and their siblings eating. And that is really so crucial for developing a positive feeding experience. And then, as we said, if there is evidence that the feeding experience is being derailed, that process of development, something's wrong, and parents have intuition.
Absolutely.
We must trust. I always say we need to trust parents' intuition. When mothers are saying something's wrong, we must listen because mothers feel it. They can see.
I mean, the parents and we also have to acknowledge the father's roles
Oh,
in there, and
absolutely,
grandmothers,
absolutely.
grandmother, grandfather.
The whole
But
family is involved in. Yeah. And as we know, very often, it's easy to say all is going fine, the baby's growing, don't worry. But we know that families can be held to ransom by mealtimes. We know we've had so many cases where the families can't go out
yeah,
because the
meal
child.
times an hour and a half, 2 hours, and your whole day is just
100%.
yeah.
Meal times can end up consuming the life of the family, the parents and the family. And we really want to come back to the positive nature of eating, looking at all the aspects and all the pieces of the puzzle to try and get that developmental process back on track.
And I think that is such a beautiful way of kind of coming to an end to say, if a child grows well and looks physically well, that does not show the distress that's happening at home. And if a parent is listening and something, as you were saying, does not feel quite right, go and ask a healthcare professional.
Totally.
And ideally, as you highlight, a healthcare professional that knows
Absolutely.
the area, because it is such a careful balance. And I think at the end, as you were saying, going to see you or coming to see me, those of us who work together, we know this fits in more with there.
Absolutely. Absolutely. And sometimes it just takes one appointment to help a family get back on track.
Exactly.
And it's so worth it just to get, just to understand, is this a problem? Isn't it a problem? Does something need to be done? And that alone can be transformational. It can really stop, the issue becoming entrenched. It's really important.
And on that note, Sandra, I want to thank you for the listeners. We'll put your contact details, your website on
Thank
so
you,
that they can
Rosanne.
get in contact with you. It was so amazing, and I'm sure I'm going to get you back.
I would love to come back anytime. Thank you so much, Rosanne.
Thank you for listening or watching this week's podcast. You can follow me on various social media platforms, which we'll share on the screen, or you can visit my website at rosannepaediatricdietitian.com. You can also like this podcast on our Step by Step Kids Nutrition YouTube channel. Thank you very much.